So, welcome everybody to the Study Club Mastermind for March 16th, 2020, a day that we will probably look back on in the future as a life-changing day. Now, I can change the slide here. We were just talking about this, but the reality that's so tough about where life is right now is we have no real frame for the current crisis, because we can't look back on this or this or this. And that's what's hard to get our heads around, is when we have no current frame. The thing is the power of laughter is really important. If you didn't see this video yet, contact me, or it's actually on my Facebook page. This is a lady that is so mad about what goes on and how people don't understand infection, and she made the little guy at the checking out use a half a drop of hand sanitizer for a half a second, and then she went over and used the keypad with no thought at all about the infection. And that's but it's the way she says it is so funny, but it's just hysterical. My funny for today, though, was a friend of mine sent me this about Tom Hanks. And of course, we know Tom Hanks and Rita Wilson have been tested positive for the coronavirus. But if Tom Hanks can survive 4 years on an island as a castaway, he spent a year in the airport without being able to leave. He contracted AIDS in Philadelphia. He was in World War II and rescued Private Ryan. He went to Vietnam and rescued Lieutenant Dan. He was on a boat and kidnapped by the Somali pirates. He survived Apollo 13 trying to reach the moon. He landed a Boeing jet on the Hudson River. If that son of a bitch dies of a coronavirus, we're all screwed. All right. That was my funny.
Good one.
The thing is,
oh my.
the thing is that as I start these meetings, you have three choices. We can watch things happen, make things happen, and wonder what the hell happened. Right now, we're a little bit on the sidelines. I'm wondering what the hell happened. Yet at the same time, this group actively makes things happen. And we're evolving, and we're making this happen with our Beyond the Oral Health membership group. Again, elite membership group for visionary dental hygienists. Become part of the movement, and you listening here are part of this movement. The movement to what? Change the future of healthcare. Be the true preventive specialist we were just talking about right before we start, to lead where healthcare can go, not just oral health, but all of healthcare. We have evolving membership levels. You'll be learning more and more about this, especially when the website goes back online. It was taken down again to switch over to the Beyond the Oral Health method, but we keep getting stuck in places. So this will be up there. If you've renewed your membership recently, you'll get a special offer for this, but we're evolving a lot of things with our membership levels and what we're going to have available for you. What you do have, we're all shut in now, and you can watch lots of Netflix, or if you want, because you're an insider, free to you, 18 plus Study Club's Master Signs. If you missed any, you can go back and you can watch them. You can do a CE and get credit for it. We also opened up to you for free medically necessary procedure coding for clinicians, 101 and 201. Those two 1-hour courses are prerequisites to our upcoming medically necessary procedure coding curriculum. Again, all AGD PACE credit, just like tonight's event is. Our next newsletter will be Monday, the 23rd. Again, the fourth Monday of every month, we have our newsletter with news you can use and so much more. And Lindsay, how did you say it the other day? We're searching the internet, we're searching the world to get information that's up to date and important for you to put together our smart bulletin every month. Also, as a sneak peek, we're moving forward with our UOR planning, and no, there is nobody that's saying that Under One Roof is being canceled. As Jackie Sanders said it to me the other day on a text when I asked her, she goes, we got to get through March. There's no way they're even considering anything of any change on these events at this point in time. And we have two important events on Friday morning. We're doing our Leading with Kindness breakfast, which you'll get information about, as well as Beat Oral Cancer, our RDH Under One Roof efforts. We're well underway in the planning of that. Susan, I don't know if you're going to be talking about that more, but Susan is pivotal in planning that, along with our chair. I don't know, Susan, are you the co-chair? Allison Stahl. But it's going to be a great event, and it's you don't have to do anything at UOR. It all happens before UOR. But we'll explain that more as we move forward. Our next study club. Is Noelle here, Patty?
Yes, I am.
Terrific.
I am.
Noelle, look at that picture. I love that picture. Noelle, tell them about this fantastic presentation that you and Rich are going to do.
So Rich and I are really excited about doing this presentation, and we know that there are a lot more offices and certainly large group practices in dental schools. About 20% of the dental schools are now installing piezo ultrasonics, and so there's some confusion about how to use it, the differences between that and magneto. And my husband's an ultrasonic engineer, so a lot of people refer to us as Mr. and Mrs. Ultrasonics. So the presentation will be looking at the similarities as well as the differences between the two technologies, and where Rich and I come together on this is that we marry the clinical side to the technical side. And Patty, thank you for the opportunity to present this, and so it's really shaping up very nicely, so thank you.
Terrific. Tell them a little bit about Rich's background.
So Rich was an ultrasonic engineer, and he was originally trained by the inventor of the Cavitron, Dr. Klaus Kliesetel. There are actually 3 inventors of it, but Rich was mentored by Dr. Kliesetel, and it was just an incredible experience for him to have such a great mentor. And Rich worked for Dentsply Cavitron for 30 years, retired from there, now has a consulting business. And in that consulting business, he's worked for most of the major manufacturers of various dental ultrasonics equipment. He helps them with their manufacturing processes as well as new instrument design. So he's one of those kind of, I would say, science geeks, and we have an ultrasonic lab in our house, and sometimes Friday night dates are spending time in the ultrasonic lab. So we are both just really geek people, and anybody that wants to come to Missoula, Montana and come see our ultrasonic lab, you're welcome to come visit.
Well, we didn't come out to see you in Missoula, but we did meet you in Billings when we spoke at Montana, and we went out to dinner. And Patty, talk about your connection with Rich.
I forgot about this. What was that?
Yeah. Somehow, as we were talking about dinner, I started using ultrasonics, maybe not exclusively, but extensively. And I don't know that I talked about this one experience I had. I had a resident, a perio resident, an Army perio resident, come up to me and say, "I did surgery on this patient, and I want to know how you did it. There was nothing for me to remove." And I said it was the tip that I had, and the tip that I had was called an EWPP, and it looked like a perio probe with a groove down the front of it that the water channeled down. And Rich looked at me, and he knew exactly what I was talking about, and he started trying. He designed it, for God's sake. I was like in awe because this is the man who designed my very, very favorite tip. It was fabulous. It's fabulous.
So we're excited to have Mr. and Mrs. Ultrasonic for our Wednesday. It's actually April 15th. I redid that a couple of times, so obviously I typed it wrong the last time, but it's Wednesday the 15th of April when our next study club will be. Of course, tonight is our study club's always our think tank, and it's More That Catches the Eyes by our wonderful Susan Cotten. In order for you to get CE credit, we have to have a couple of things in place. And one is to have the course description, which you see there, and then put your name, first and last name, in the chat box so we can give you CE credit. Now, our other system was supposed to be up and running this month. We still aren't yet, but so we're going to have to go through roll call. So hello, who's here? Patty, help me with this. And Lindsay, you're keeping track of this, right? So if I say your name, please tell me that you're here or not. Amy McClintock?
Yeah, I'm here.
Great. Barbie Lynch?
I'm here.
Terrific. Krista McConaughey? Nope, no Krista. How about Connie? Connie Simmons, are you here? No Connie? Okay. Deanna Ashcroft?
Yep, I'm here.
Oh, terrific. Great to hear you here. Denise? Nope. Diane Lemansky? Diane Marcella? Ellen Anderson?
Present.
Terrific. Ivy? Ivy Walchuk? No? Okay. Jamie Collins. Jamie, are you here yet? Jamie? No, Jamie. Okay. Jean Wintz? Not yet. Jennifer Bruckner? How about Jennifer Z? Nope. Joy Holmes? Nope. Kendra? There's Kendra.
Hi, I'm here.
Great to hear from you. Karen Siebert.
Good evening.
Great to see you again, Karen. Karen Bogart. Catherine Whitehead. Layla Christensen. Linda Jorgensen.
Hey.
There we are. Linda Keltner. Lindsay Hill.
Hello.
Lisa Graziano.
Hello.
Lisa, how the heck? I'm saying your name wrong. Tell me how to pronounce your name better.
No, you said it right. Lisa
Oh, okay.
Graziano.
Okay. All right. How about Lucy? No, Lucy. Boy, she was really great to see her and meet her and work with her at the codes meeting last week. Margaret Thibodeau? No. Michelle Race. Hey, Michelle.
Present.
Wonderful.
Hey, all.
Michelle. She rocked it at the codes meeting too. You'll hear more about that later. Nicole Fortune.
Hi, everyone.
Terrific. And you were there in spirit with us. We know that when we were talking about perioscopy and the other technology. We didn't get very far with those, but you were there with us. Miss Noelle, of course, say hi again, Noelle.
Yep. Hello, everybody.
There we go. I see Nancy Brohan on the list too. Say hi, Nancy.
Hi. Hi, Nancy. Hi.
Nicole Flaherty, again, she's not on the list, but I see her there on our list. Nicole? Oh, no, that's you.
Teresa
No,
Shepherd.
that's not
Yeah.
you. That's Michelle. Okay, that's right. Paige?
Teresa.
Teresa. Paige, not here yet. Patty B?
I'm here.
Patty Me? Patty Korecki? Not yet.
Let's see her.
Paula Quinn? Go, slide. Rhoda, are you here, Rhoda? There she is.
Yes, ma'am.
Hello.
Terrific. Sandra Berger? Siobhan? Sherry Lukes? Cheryl, it looks like she's offline, but Cheryl Scott looks like she's here, but she's offline right now.
It says mobile.
Oh, she's at mobile? Okay.
I'm on my
I see. Shirley Kowski? And we're really hoping Susan's here, right, Susan?
I'm here.
Teresa Ramirez? Teresa Shepard, sometimes known as Nicole Flaherty. And Val Dangler. Is there anybody else here that I missed, that we missed your name? Okay, great. Course attendance, again, your certificates are already done. We will get those out to you. We'll turn them around as quickly as possible to get those to you. I want to say thank you again to everybody that contributed to our getting ready for the codes meeting by being on a committee or being on a group. And I particularly want to thank the 13 of you that showed up. Now, right here, we have this great dinner we had at, Patty, where'd we have it at?
Rosebud.
Rosebud. Oh my God, did you miss the dinner? It was fantastic. It really was. And this is the meeting. This is some active meeting. They actually had, because of the coronavirus, they spread out the tables farther, so the participants, the voting members, were not next to each other as much, and so they didn't have as much room in the gallery. They actually had to set up chairs because we had 13 of our group members plus Tammy Filipiak from ADHA were in attendance. Hooray. Great job. We didn't get everybody's picture. Some people had to leave early, but there's the pictures of all of us. And we did have some successes. On Sunday, the 29th, should be on your schedule already, 7 p.m. is our next DCC. We will give you a full report of what's going on, what happened at the meeting, as well as discuss and choose leaders for next time around, because it's already immediately time to start planning the next time around. I already have a leader, which is Siobhan Healy, said she would lead one of our groups next year already. Yay, Siobhan! So anybody else that's interested in that, again, by that point, we should have our IOH travel grant, which we're going to be calling our Travel Trailblazer Award, available. We'll have more details on that as we go forward, but that way it'll help people that step up to leadership and participation with funding for getting to the to the CMC meeting next year. Preview. We had success. We got a code through. The Dental Codology Consortium had a code that got through, and it was the one on vaping. And well, that wish those wouldn't keep closing, but it was actually, there was some language that was added and all that, but when it passed as we wrote it. So that was really huge. The DCC had a code 6 pass. Never happened before in the history of mankind. That's the first time, the first of many, we hope. We'll be telling you on the meeting on Sunday a lot more about, again, the details of what happened, as well as the discussion at the end of the meeting that is just like, whoa, and what they're going to be doing in the future. We'll see how that all works out. But again, come on the 29th at 10, and we will talk more about that. Susan will talk specifically about some of the submissions, all the submissions around oral cancer, oral and pharyngeal cancer that we submitted, and what we did win. We won something there too. Maybe not as much as we had hoped, but we did get a win in that arena also. We almost got a win on one where they're going to eliminate the provider language, but we didn't quite make that one. But again, we'll tell you more about those details at our next DCC meeting. So remember, this is a think tank. It's cool. It's a cool, safe place. If you have questions along the way, you have comments along the way, you just want to talk about something, please, we want you to participate. So without further ado, I am going to take this screen and I'm going to hand it over to Susan, and Susan's going to run her own slides from here. All I got to do is figure out how to get there. I'm getting there, Susan.
Okay.
Seriously. And Susan will take over. If you don't know about Susan, she's an amazing, gifted speaker and presenter. Her passion is oral and oropharyngeal cancer in ways that she's going to help all of us to know. Have you got the screen, Susan?
I do.
Okay. She also was
Okay.
a fantastic leader of our oral cancer work group. So go for it, Susan.
All right. Okay. Well, let's talk for just a minute about what happened at the CMC meeting. I think they were against this enhanced oral and oropharyngeal cancer screening code before we even got up to speak. They were just adamantly against this. What we did get from this is they did remove the language to be done, the oral cancer screening to be done when indicated from the comprehensive exam. And from the periodic exam, as it reads, they moved a comma. So it doesn't read oral cancer screening when indicated anymore. The perio exam is still when indicated, but not the oral cancer screening. One thing that was said, we read to them what the ADA position change was back in September, saying that we should screen for oropharyngeal cancer as well as oral cancer. And one of the head and neck specialty groups said, I challenge anyone to say they can do a thorough oropharyngeal screening. And if I would have had my balls about me, I would have stood up and said, I accept that challenge. However, I didn't want to piss them off either, because we want to go back. So, and we'll talk about that. As definition, what the oropharynx is, we can screen that area. So, yeah, rather disappointed. I mean, I walked into it thinking we are going to get this code, and they shut it down. So,
but what did you think? But didn't you find the whole meeting different than you thought it would be, though?
Yes.
Yeah.
Yes.
Yeah.
It was quite the experience. And gosh, if you can go next year, go. It really was an experience, and to go with this amazing group of hygienists and women, that was the icing on the cake. So if you can go, absolutely go. I'm just honored to be a part of knowing and working with all of you. Thank you, everybody, for what you did. So let's talk tonight. Head and neck, oral pharyngeal cancer screening. And it is more than what catches the eye. In school, we're taught to look and to feel. But what we know now is it really is more than that. Okay, it's not advancing.
You might have a bar in the way. You have to get out of the way.
Sometimes
Well,
it takes a second to advance here.
Does it?
Yeah, but
Oh, there we go. Okay. All right. So I just want to start off real briefly. Right out of hygiene school, I was so good, so thorough at this exam. I did it every single patient, every single time, very thoroughly. And as my career went on and I was dictated to do all of these different things, some of them a personality interview, get the patient the warm towel, it was the experience. I failed myself and my patients. I always did the exam, but I have to tell you, I didn't always palpate the thyroid. I didn't always palpate extraorally until this lady right here became my patient. And I'll try not to cry talking about her. Her name's Evelyn. Before she became my patient, she was diagnosed with HPV oral pharyngeal cancer. She was also diagnosed with HPV cervical cancer. She was very immunocompromised. I've been seeing her for about a year, and I was doing everything I knew to help manage the oral side effects of her cancer. And it's difficult, but we were kind of staying on top of it. But after I had seen her for a year, she came in for her hygiene appointment, and we were, how we talk about our weekend plans. She looked at me and she had tears in her eyes and she said, "Susan, I'm going to my friend's wedding this weekend, and I just want to be able to go and smile and laugh and take pictures and talk without that constant fear that somebody will see what my teeth look like." As hygienists, we know the devastation that occurs to the oral cavity when somebody has cancer, and especially oral and oral pharyngeal cancer. And it wasn't until that moment that I realized how this cancer had affected her entire life. And she changed me. I went back to what I was doing right out of hygiene school. But it also became my passion, and I needed to know more. So that's when I decided to be part of the change. Oral cancer screening saves lives. And I know I became fanatic at it, and people in my office were like, "Oh, here she goes again, talking about oral cancer." But this is what it does. This is the extreme. And a lot of us know Christine through the Oral Cancer Foundation, and perhaps you've seen her on commercials lately speaking for the CDC. But Christine was a smoker. She didn't think she was really a smoker because she didn't smoke that much. She is a 3-time oral cancer survivor. 3 times she has gone through this. And I know Christine, I've gone to dinner with her. Sometimes she can eat some cottage cheese, and sometimes she can eat a little bit of applesauce. She lives on a feeding tube. She lost her job. She lost everything. to oral cancer. And she is the most amazing woman I know. But this is what this cancer does. One person every hour of every day in the United States dies from oral or oropharyngeal cancer. This year in 2020, the number is approximately 53,500 will be diagnosed. However, let me tell you about this number. And talking with Brian Hill, when he puts this number together, he uses a combination of 3 to 4 sources to get an accurate number. And this year, there's only one source to go from. The other sources have not put out their data. So last year, the number approximately to be diagnosed was 53,000. From the data they have this year, it's at 53,500. However, we know it's more. This cancer increases 3 to 6%, the diagnoses 3 to 6% every year. And so Patty mentioned, you know, and they have on the news where we're at with the coronavirus, what we know now, that data that we have, we're behind. Same here with this figure. We are 4 years behind. So this number, 4 years ago, that's where the data is.
Can you share, Susan, who Brian Hill is? Some people might not know Brian as well as the rest
Okay.
of us.
Okay, Brian Hill's the founder of the Oral Cancer Foundation. He's also a 20-year HPV oropharyngeal cancer survivor. He and his wife actually owned a dental implant business before he was diagnosed. So he had ties to the dental industry. And right before he was diagnosed, they sold their company. So when he was going through his treatment and afterwards, there wasn't anywhere to go. There wasn't one place to go for information, for support, for current research, all of these things. And so he started the Oral Cancer Foundation. And if you haven't visited the website, please go visit the website. It's one of the best things out there. And if you have patients that are diagnosed, refer them to the Oral Cancer Foundation Patient Support Forum. It is excellent. They'll get so much support. Christine, she actually oversees that support forum for patients and their family members. So this is a group I volunteer with in Denver. Providing Chance is our name. The man in the back in the blue, he is a head and neck oncology ENT surgeon. He's an amazing man, and I volunteered with him for the last 2 years, and I've just learned a lot from him about this and about screening. So the objectives, Patty went over those. I want to start with a story, and this is Joanne. Joanne was diagnosed with stage 3 squamous cell carcinoma on the lateral border of her tongue after being dismissed several times by her dentist. You're not at risk. Your lesion, oh, that's nothing. It doesn't look like anything. We've all heard these stories. But Joanne, before there was a lesion, she experienced pain. That was the first thing that she goes back to. She had pain in her tongue before there was any lesion on her tongue. Joanne, she's a biomedical researcher at the University of Hawaii on Oahu, highly educated. She said, I never knew there was an oral cancer before I was diagnosed. I'd never heard of it. And that's why I think it's so important. You hear this a lot of times from survivors. I had never heard of this cancer. I didn't know it existed. That's why it's so important we talk about it and we educate and tell them we're doing an oral, head and neck oropharyngeal cancer screening. This is James and Mona. James, healthy guy, athlete growing up. He's been married to Mona for 40 years. James, the background is Denver there. James owned his own business. He had a tech business in South Denver. And he also worked at FedEx. So he worked a lot. He was a workaholic. But it started to get to the point where he could not drive the 25 miles home from work without stopping to take a nap. He had to stop, he explains it, at the Target and take a nap for about anywhere from 15 minutes to a half an hour before he had enough energy to finish driving home. And he knew it wasn't right. He was exhausted. He called his doctor, made an appointment, went in, but about 2 days before he went in, a lump appeared on the side of his neck. How fortunate for him, right? But his doctor dismissed it. He said, James, look at you. You work 2 jobs. You are on the go all the time. No wonder you're exhausted. Take Mona on vacation, maybe quit your second job, but you got to do something. Oh, and the lump on the side of your neck, here's an antibiotic. If you're not better in a couple months, give me a call. We know the stories, right? Well, James knew something wasn't right. The next day at work, something dropped on his toe and he broke his toe. And he said, this is my chance to go in again. He said, I know they can't do anything for my toe, but I'm calling the doc and I'm telling him I'm in a bunch of pain. So he did, and they saw him again. And he told the doctor, he said, something's not right. I want every test, scan, everything that you can do. He said, I've got good insurance. I want to use it. Do all the tests. And so they did. After everything was done, James went to his appointment with the ENT he was referred to, and he waited 4 hours before the ENT came in to see him that day. And the ENT walks in and he says, I'm really sorry, James. He said, we've been so busy today. You know, I know you've got your scans, but could you come back tomorrow? And James is like, you know, I could, but could you just take a look at my disc with some of the scans on there? Just take a minute to take a look. So the doctor went back to his room, came back about 5 minutes later. James said, he looked as white as a ghost and said, James, let's finish our appointment. I want you to come back here with me. Well, James was diagnosed with HPV, oropharyngeal cancer. He had an HPV tumor that was blocking 80% of his airway. No wonder he was exhausted. He wasn't getting oxygen. So James went through treatment. That's his mask, obviously. Thumbs up during treatment meant all is good. If his thumbs went down, it meant get me out of here now, because they can choke, they can aspirate. There's a lot of things that can happen when they're going through that horrific radiation treatment. And it doesn't just affect intraorally, that's what it did to the outside of his neck.
Oh my God.
There's more I could tell about. Yeah. Pretty extensive. When James comes with me often in Colorado to share his story, and he talks about getting addicted to painkillers and ruining them financially. And it's more than mucositis, xerostomia, and rampant decay. This cancer affects their entire lives. But what I want to point out about James and Joanne, their first symptoms, it wasn't something that could be seen. And they were brushed aside. They were pushed aside, just like with the Titanic. When the Titanic, they got all of those warnings of heavy ice in their path, but they were in their box. They weren't looking outside of the box. They weren't paying attention to those warning signs that were coming in. Well, are we paying attention to the warning signs of patients that are coming in? It's more than what we see. What's our process to deal with this? Because so many times it's going to be, we're going to notice all of these symptoms. They'll report those symptoms. We need to pay attention to those before we hit the iceberg and epic tragedy occurs, just like it did with the Titanic. So what's a process? We need an office system. We have office systems for everything in dentistry. What's our office system for cancer? As the ADA says, we need an updated dental, health, and social history. The entire team needs to be educated. I can remember when I first got on my passion about oral cancer, and I was bringing back patients for follow-up, and I was fortunate, my doctor I worked with, he's like, you think they need to go for a referral? They're going for a referral. But the front desk, I found, really became irritated with me because they didn't understand why I was doing all of these additional things. So to get the team on board, they need to be educated. But you know, it's not just for the office and for the patients. They need to know it for them too. They need to know it for their families, for their friends, and educate the public, our patients, and the general public. I have been scouting dental websites, and there is more information on how we remove calculus and how we whiten their teeth. And all it says on the majority of them is oral cancer screening. We should have things on the website about HPV, how it's transmitted, signs and symptoms, because that's where people are going nowadays. They're looking at websites. That information is critical to be on websites. Referrals. Who are we referring to? And are we referring on a timely basis? I was told a story at RDH Under One Roof by this hygienist. And we know this story. She had found a lesion on her coworker hygienist's tongue. And the dentist they worked for said, oh, it's nothing. Oh, it's nothing. Well, it persisted. He looked at it again. It's nothing. But, you know, if you want to go to my buddy, the oral surgeon down the street, he'll take a look at it. And he looked at it. Oh, it's nothing. Well, this hygienist is no longer with us. She was finally diagnosed with stage 4 squamous cell carcinoma on the lateral border of her tongue. Who are we referring to? If those oral surgeons or ENTs are not doing those biopsies, need to find somebody else to refer to. And a synchronized screening, are the hygienists and the dentists in the office screening the same structures? They don't have to do it in the same order, but are we all screening the same? Because we hear it. You know, I saw Susan last time, and she didn't do all of that you just did. How come? We need to be screening the same. Documentation. NSF doesn't cut it. WNL, we never looked, doesn't cut it. We've got to be better with our documentation. And follow-ups. Follow-up, if you aren't referring something immediately, bring them back in 2 weeks and check on it. Follow up, but also follow up on your referrals. What was the diagnosis? what was done. Did that oral surgeon even do a biopsy? Or did they say, oh, it's nothing? So when we send somebody, follow up. So last year, MD Anderson put out this article, 10 symptoms of cancer you shouldn't ignore. And this isn't oral cancer, this is any cancer. 10 symptoms of cancer you shouldn't ignore: fatigue, trouble swallowing, a nagging cough or hoarseness, unexplained weight loss, a mass or a lump, a sore pain, change in mole or wart, unusual bleeding or discharge, change in bowel or bladder habits, indigestion. Is a light bulb going off, you guys? How many of these relate to our cancer? Now, I know it says 10, but they had indigestion with trouble swallowing, so I separated those two for good reason, because trouble swallowing, difficulty swallowing, is one of the big symptoms that we need to pay attention to, especially as far as oropharyngeal cancer goes. So what are our signs and symptoms we need to pay attention to? These are the signs and symptoms, and they're persistent. Anything that persists for 2 weeks or longer: pain, mass or lump, a persistent swollen lymph node. And when we talk about those, it's the painless lymph nodes we're concerned about. We know that. Typically, those painful lymph nodes are when we're sick. Difficulty swallowing, a change in voice, hoarseness, persistent cough, persistent sore throat, persistent numbness, ear or jaw pain, and it's usually one-sided ear pain, unexplained weight loss, something caught in the throat and it feels like it won't go down. So when they're swallowing, feels like something's there and it won't go down. These are the things that we need to pay attention to. We need to ask, and they should be on the health history form. So both a written questionnaire and verbally, because we know that when patients fill out the medical history form, they don't always mark everything, but when we have a conversation with them, it triggers it. Oh, yeah, actually, I do. And all of these can be asked. We can ask these about these signs and symptoms when we're doing the head and neck oropharyngeal cancer exam. So we know historically tobacco and alcohol, high use. We now know HPV, but what else? What else are American Cancer Society, OCF, MD Anderson? What is everybody else saying? Graft versus host disease. It's when donor bone marrow or stem cells attack their recipient. And it's more common after the marrow has started to make healthy cells. And some of the symptoms of this can be mouth ulcers, a rash, and abdominal pain. But they're finding that when somebody has this graft versus host disease, they are at a higher risk for oral cancer. Previous cancer, previous head and neck oral cancer, once they've had it, they are at a higher risk. And really, some of the research is showing any cancer. And we know that the squamous cell carcinoma and the HPV, it's metastasizing in some people. Prolonged sun exposure, increased for lip cancer, but also skin cancer. Ill-fitting dentures and poor oral health. why do most of our patients have dentures to begin with? Because they have those high risk factors for oral cancer. So, you know, the office I worked in for so long, we had a patient that full mouth, you know, upper and lower dentures, and he came in, he's like, you know, this upper denture, it just hasn't been fitting the last several months. And I've got a sore. I need you to fix that, doc. Well, he had oral cancer. He was a smoker, and he's no longer with us. And that's one thing that I personally think we should do. It's just my own personal opinion that when we give somebody a upper and lower denture, don't just send them out the door. Set them up on a recall. They're high risk typically for a lot of different things. Bring them in every 3 months, 4 months, 6 months. Check on those dentures. Do that head and neck oropharyngeal cancer exam. See if they're cleaning their dentures. I mean, there's just so many things that we need to do for these patients rather than just let them go. And that's what our office did. We would give them dentures and let them go. Let's get them on an oral health recall and take better care of them. So poor nutrition, diet low in fruits and vegetables. However, some research is showing that a diet high in vitamin C and fiber can cut the risk for oral cancer in half. Immunosuppressive drugs. A family history of squamous cell carcinoma can put someone more at risk. Weakened immune system. Lichen planus, GERD. With the lichen planus, there's some research that they're looking at. Someone with severe lichen planus and hep C, they're thinking may be added risk factors for oral cancer. And we know that persistent severe lichen planus, it should be sent off to be looked at by a specialist, to be biopsied. Drinking mate. Mate is a tea. They drink it heavily in South America. The mechanism of action for a risk factor for oral cancer, they're really not sure about yet, but they think it's the polycyclic aromatic hydrocarbons that is putting this tea as a risk factor. But they're seeing that this is causing oral cancer. Of course, it's when somebody is using it heavily and consistently over a period of time. It's not one or two, we know that. Chewing quids of beetle, heavily used in Southeast Asia. It's actually the 4th commonly used addictive substance in the world. And here in Denver, we have a large community of people that are using the quids of beetle. So those are some risk factors too. Are they on our health history form? Are we asking about all of those? And a big takeaway is just, if it's not right, it's wrong. React. Just do the right thing. Refer. Question the patient more. Find out more about what's going on. And refer on a timely basis. So this is Caitlin. Caitlin, at 19 years old, right after she started her freshman year of college, was diagnosed squamous cell carcinoma on the lateral border of her tongue. As we know, those college students, they come in that summer before and they get dental work done before they head off to college, right? That's what Caitlin did. And she had some restorative work done, and they told her, Caitlin, don't chew, wait until your numbness wears off. And she said, I didn't listen to him, but it saved my life. because she bit her tongue. And after the numbness wore off, it was really sore. And she looked at it and she's like, oh, wow, look at what I did to my tongue. There's this huge sore on it. So she went back in and they looked at it. Wow, Caitlin, you've got to stop biting your tongue. Look at that huge sore you've got. So, you know, if you can't stop that, we might need to make you a night guard. So Caitlin went off to college and her tongue was still sore. She couldn't avoid biting her tongue. So when she went back, it was around Halloween. She went back to her dental office. They're like, you know, we've got to get you in a night guard because you're just grinding away on the side of your tongue. This has to stop. So she went back to college and came home for Thanksgiving. And that's when they sent her to the oral surgeon, and she was diagnosed with squamous cell carcinoma on the lateral border of her tongue. If anything persists, and I know I'm preaching to the choir, to you guys, but we've got to get the word out. It just, if anything persists, it doesn't matter age or risk factor, or if our biopsy eyes think it's nothing. It needs to be referred. And I didn't put it in here, but I have this slide and I should have. It's like biopsy eyes are not a thing yet. We don't have them. Those dentists do not have them. And as hygienists, we go with our gut. And we know. We just have this innate feeling when somebody should go. But that's Caitlin's story. And so you can see on the side, they did a nick dissection. They removed around 30 lymph nodes. She was at the Mayo Clinic in Scottsdale, Arizona, and they decided because of her age and her health not to do radiation treatment. So she did not have radiation. She still lives in Arizona and she goes in very frequently. It was every 3 months to have tests to get checked up on, and she's doing great. In fact, actually last weekend Caitlin got married. Yeah. And she's a teacher, and you know, you can hear a little bit of a lisp with her tongue, but she's doing great. She is really doing good. I don't know, I'm kind of teed off at the ADA, but I have to show this.
Yes, we are very teed off at ADA, aren't you? But it wasn't just ADA that voted against us. Every one of those specialty groups also voted against us. Let's put the ire on the entire profession of all those professional associations.
Yeah, it was the whole group. But so, you know, last year at their House of Delegates, and we all know this, they voted to include oropharyngeal cancer and to screen all patients. However, at that meeting last week, they did not want to add oropharyngeal, and they didn't want to even consider it or talk about it. I'm shocked. But we can screen for oropharyngeal cancer. And it's not just looking, it's a lot of those things that we just talked about. Risk factors and signs and symptoms. So let's talk about screening. So what age do we start screening? It's interesting, the responses that I get when I ask. Some people will say, well, around 14 or 15, you know, when they become an adult prophy, but then a lot of people say very first visit, and that's when we should. And you guys know that, and I know you guys do it. Very first visit. And with kids, of course, we're not going to tell them we're going to do a cancer screening on them. We make it fun. Stick your tongue out at me, buddy. Move it side to side, you know, just like we do everything else in the dental office. Because this 6-year-old, Morrisanne Henson, in the UK, she had lost ENF and her mom noticed a pea-size knot right there. And she's like, well, that's odd. So she took Morrisanne into the dentist, and that dentist was right on top of it, sent her off, and she was diagnosed with squamous cell carcinoma on her hard palate at 6 years old. Is it rare for that age? Absolutely it is, but it's a possibility. So we need to look. We need to look. How closely are we looking? Loops and a light, we need to use all the technology that we have, all of our enhanced technology that we have. Did you see how I emphasized enhanced? They didn't like that word either.
Even though it's their word. In the CDC
Absolutely.
companion, that was where we got that word from, and they still
Yep.
voted it down. Their
Yep.
word.
Yeah, they did not like the word enhanced. What exactly is enhanced? So, yeah, but we need to use our technology, everything that we have at our disposal in dentistry, not just to save teeth, but to save lives. Loops and a light. I absolutely think lights on loops are necessary. And I understand some people don't like them or can't afford them. Use the proper, oops, just a second, you guys. Told me my battery's running low. Oh, it came unplugged. Okay, there we go. But loops and a light and an intraoral camera. We would take preliminary pictures of every tooth, every quadrant at my dental office to get a baseline reading of the dentition, of the hard tissue in the mouth. So in case something changed or that margin started to break down, oh, we could jump on that and we could restore that tooth again. Same thing with soft tissue. Take those baseline intraoral soft tissue pictures, the tongue, the buccal mucosa, the floor of the mouth, the palate, the uvula, get those baseline readings. We know that we take photos when we see a lesion, but let's start taking those baseline readings when there isn't one. So if somebody comes back in and they say, oh, I've got this sore. Well, how long's it been there? I don't know. You can look back at their photos to see what was there the last time we saw them. We have something to go on.
We take pictures of our lunch. Let's take pictures
Absolutely.
of that. You know, just cracks me up that
That's
we're
true.
so we only want to do what we want to sell dentistry. You know, with the best diagnostic modality that we have is pictures, 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 pictures.
Yep.
And
Yep. And it's document.
Yep.
And it's not, and it's also liability. It helps with liability. You know, that was their big thing, is what they told, what Patty was told was that one of the big reasons they didn't want this code was because if there was a specific code for this exam, this screening, and if something wasn't found, if something was missed, they would be held more liable.
It's like saying you're more
Interesting.
pregnant.
Right.
Yeah.
So,
I mean, they're liable anyway.
let's not have medical codes for the mammogram or the pap smear or anything else, because what if they miss something? I mean, the thinking is ludicrous. It's just crazy. Anyway, so here's a review. Here's just a picture, a review of the nodes that we should be palpating. And I'm going to play a video here. This video is
Susan,
what?
we won't be able to hear the video. The videos don't work.
Oh, you won't?
No, videos don't work.
seriously.
Maybe what you can do is send me the link to that video, and I send out people CE, I will send them the link to watch this video.
Okay. Yeah,
Okay.
it's just a good review of palpating the thyroid.
Okay.
Oh, you could narrate it.
You want me to? I can show it. I mean, it's a good.
Yeah, because it's a physical palpation. Yeah, go ahead. But we won't be able to hear it.
Okay. Can't hear it.
A little bit.
I could hear it.
I can hear
I
it.
can hear it.
I'm now going to demonstrate the thyroid exam. The key to the thyroid exam is knowing the anatomy. So if you follow along with me and put your finger on the tip of your chin, on the mentalis muscle, and then slide your finger down the midline, the first hard structure you hit will be the thyroid cartilage, or the Adam's apple. You're actually going over the hyoid bone, but you generally don't feel it very clearly in the midline. So the first thing you hit is the top of the thyroid cartilage. Slide your finger down the edge of the thyroid cartilage like the prow of a ship, and you will next hit the cricoid cartilage, and this is the cricothyroid membrane, and then below the cricoid cartilage will be the first rings of the trachea. It's important to know this anatomy because the thyroid gland does not really lie anywhere near the thyroid cartilage despite the name. The exam is best done by getting behind the patient and once again using my anatomy, finding the thyroid cartilage, the cricoid cartilage, the first two rings of the trachea. I then put my fingers in the midline over the first two rings of the trachea. That's where the isthmus of the thyroid lies. I then flatten my fingers. It's almost as though I'm trying to choke the patient. And I slide my finger slightly to the side. And now I ask the patient to swallow. And I'm concentrating on whether one set of fingers went up disproportionately compared to the other. Once I've done that a couple of times, I can then push the thyroid gland over with one hand and palpate the lobes with the other hand, and then do the same thing this way. Don't forget while you're at it to do a complete lymph node exam and also to look at the hand to see if it's sweaty and if there is a fine tremor.
And looking at the hand for fine tremor or sweaty is because that could be indication of hypothyroid.
Still send me the link. I'll send it out to everybody because watching that a couple times is probably going to be helpful.
Yeah, okay, I'll do that. Okay, so let's start with the extraoral exam. So the patient should be sitting upright to do the extraoral exam. And this is Stan from Crown Seating from Dental Works. And sitting upright, because if the patient's lying back, as it's been explained to me multiple times by many people, and it's true, things settle. We need to have that patient sitting upright. And you can't properly look at the hairline on the back of the neck or palpate those occipital nodes if the patient is lying back in the chair. So sitting upright is key. And with this position here, especially if somebody has maybe a thicker neck, to palpate those lymph node chains around the sternocleidomastoid, if they turn their head, put your hand under their chin and they drop it slightly, it makes that sternocleidomastoid muscle pop. And we can palpate that much easier. And that's an up-close view of that. So what I'm going to be showing here is not everything. I'm actually working on a video for the full exam. So what we're going to show today are some highlights, because I feel like you guys know about this extraoral exam. So I'm just going to hit some highlights here for us today. So this right here on the right-hand side, you can see Can you see my arrow here where I'm pointing
No.
at all? No? Okay.
Oh, yeah. Now I can.
Okay. If you look on the left side, the white,
Oh, there we go.
Right.
Now.
yeah, that's the bifurcation of the carotid artery. And over here, that's the bifurcation of the carotid artery. And what this is a mass around that carotid artery. I love it when people who've been to my class send me pictures of things that they found. And this was found actually by a hygienist. She had just, she'd seen the patient. She started having the patient turn their head and drop the chin down and palpating that way that we just observed. And she found this mass. It was not painful. The patient hadn't noticed it at all. 63-year-old female. It was hard on palpation. It was movable, no pain. They sent her off and she was diagnosed with a benign carotid artery tumor. It took 5.5-hour surgery to remove the tumor. And the doctor said to this lady, "Who found this?" And she said, "My hygienist did." He said, "Don't ever leave that hygienist. She saved your life." Right?
Yeah.
Yeah, she was at risk for a stroke. She could have died, not because it was cancerous, it was benign, but where it was. So just to reiterate the importance of that extraoral thorough palpation. So we want to check all around the hairline. We want to lift up their hair, ask them, "Do you mind if I lift up your hair?" Look around the back. And what I do is when I come around the back, I have them dip their chin down. Great time right back there. You can get right behind them, especially when you're standing up, and you can palpate those occipital nodes. You can look at the ear, behind the ear when you're back there. Especially on our men, check their scalp. And on women, check the part, check the ears, check the nose.
Oh.
Skin cancer is the most diagnosed cancer in the United States. Ask them, are they wearing sunscreen? What are their precautions when they're outside? And here's why we want to have our loupes and a light on when we do that extraoral exam and we're looking at the skin. This was a basal cell carcinoma. This is actually me. This is my third on this picture. This is my third round of skin cancer on my nose. If you look to the left in this picture right here, you can see a round kind of reddish raised area. That was my second round. And this actually went into the rim of my nose. I lost the rim of my nose right here. And after they removed that skin cancer the next day, they put me under general anesthesia, and a plastic surgeon removed cartilage from behind my ear, built up the rim of my nose, and took a graft and placed it right here. I had the same skin cancer right out of hygiene school, 3 months after I got out of hygiene school, on this side of my nose. And you can see right here, there's a little bit of a scar, because what they did was with this is they cut me from here all the way up to here to right up my nose to get out that skin cancer. That one was pretty barbaric. But this is what we can find when we look. Basal cell is not typically going to metastasize. It's very, very rare. But what it does is it moves into structure where it's at. So it's imperative that we find those and refer our patients. We're not diagnosing, but we're just like we do. We're telling them, we see something that's not quite right. Do you see a dermatologist? Refer them. So this was sent to me by another hygienist. And this lady had just been into her dermatologist a few months earlier for an overall check and nothing was found. She went to a new hairstylist and this hairstylist found this in her part. And she said, you know, that doesn't look quite right. I think you should go have that checked out. And that's the Mohs surgery. And that's what they do.
Oh my
It's
God.
called, yeah, it's called Mohs.
Warn us on these pictures. Oh my God.
Yeah.
Sorry.
So,
Oh my
so if a hairstylist can take the time and say, hey, that doesn't look quite right, so can we. But with Mohs surgery, they have to take a bigger portion than what they think because they want to get the border, they want clear margins around those borders. And sometimes they have to go back in. On my one, they had to go back in 4 times. I was in there all day long, getting repeatedly numbed up on my nose until they got all of the cancer out. But that's what they do with the Mohs surgery. And then to close that up, that's what it looks like. And it was melanoma. But that's why we take the time to look at all that we look at. It's a head and neck oral pharyngeal cancer exam. And again, if it's not right, it's wrong. Some of these things doesn't mean it's always going to be cancer, like if they have a persistent cough or change in voice. Some of those things, no, it's not always going to mean it's cancer, but it's not right. So it deserves a referral to be investigated. And the reason I say that is I became very sick and I lost my voice. I got well, but my voice never got better. It was raspy and it was persisting. And I'm like, crap, I talk about this. I've got to go in. So I went into my favorite ENT in Boulder, Colorado, and he smiled. He was so kind. But I had a damaged vocal cord. And I had to do some therapy for it. So just to reiterate, if it's not right, it's wrong. Doesn't always mean it's cancer, but react and refer that person. And not just our patients, but us, you guys. Are we paying attention to ourselves and our family and our friends and our colleagues that we work with? Because I don't know about you guys, but when I was in clinic, it was like, I'd be like, hey, Margaret, you've got a cancellation and I've got a cancellation. Get over here real quick and I'll clean your teeth. Did we always do everything on our colleagues that we do on our patients? No. Do they deserve it? Yes, they do. Just like our patients do, because we're susceptible too. So before we move into the intraoral portion, in 2017, the ADA, once again, they talked about sleep apnea. And part of that policy states they emphasize the dentist's role in screening for sleep-related breathing disorders. They're significant. We know that. That's another important exam that we do, screening that we do. And the reason I mention this here is because 4 years ago, I took courses to become an orofacial myofunctional therapist, and my eyes were opened when I took that course because they were talking about Mallampati score and tonsil score and documenting those, because those are important when we're screening for sleep-related breathing disorders. But they're also very important when we are screening the oral pharynx. So if you're not familiar with Mallampati classification, that was historically, it's been used when they intubate somebody. You know, what will be the difficulty or the ease of intubation when somebody goes into surgery? We have class 1, 2, 3, and 4. And based on those different classes, it tells us what structures of that oral pharynx that we can see. And so why is that important for us? Because we are screening the oral pharynx. What structures of the oral pharynx can we see? And if we can't see them, we need to document that. But before that, we need to do all that we can to observe these structures. Evaluating the tonsils. So the tonsil, it's the Brodsky score. When we evaluate the tonsil size, goes from grade 1 to 4. Tonsils, we know, should be symmetrical in size and color. And if they're not, it's not right, it's wrong, so they need to be referred. Does it mean it's cancer? No, it doesn't always mean it's cancer. But if they're not symmetrical, the person needs to be referred to an ENT to see what's going on. So if somebody they have a class 4 Mallampati or even a class 3 Mallampati, and they've got a grade 3 tonsil, we're not going to see the posterior wall of that throat. We need to document that. It could be any variation of those, but be sure to document, because we know if it's not documented, then it didn't happen or it wasn't done. So what I've discovered for myself is to do this thorough intraoral, and especially evaluating that oral pharynx, is to remain standing and to lie the patient back at about a 45-degree angle and bring them up. So I can move side to side, right to left if I need to, but when I'm standing up, I can look clear back. I've seen the epiglottis so many times now that I stand up and I have a cooperative patient. It's amazing. But when I'm sitting in my chair, I can't see thoroughly when I'm screening that oral pharynx. So I don't know what you guys do, but try it. Try standing up, see if that helps. So a review here of what we want to do. We want to pull out that lip, pull up the lip, look at the frenum, you know, take a good look at those structures. You know, it's more than our little massage. I don't know. Yeah, we like to make them feel comfortable, and we don't like to hurt our patients, but we do need to retract and to pull and really look at things thoroughly. Palpate the hard and soft palate. Don't just observe it, palpate it. What I like to do is, before I even start this, I like to take a mirror and I like to take just a general look around at everything to see if anything's really popping out at me, you know, and we're assessing everything. Are there any abscesses, fractured teeth? You guys know that. We're looking at everything.
This is why I've said often, Susan, and see if you agree, is that if somebody is actually having a thorough head, neck, or oropharyngeal evaluation, they can't not know they had it.
Right.
Even if you don't talk about it, if you're doing it right, they know they're having something done.
Right. Exactly. Exactly. And then the tongue. So, you know, the tongue, we want to assess the tongue for mobility before we even start really examining closely. So have them stick the tongue out, move it side to side, and touch the tongue to the roof of the mouth right behind 8 and 9. And by doing this, you know what we're also doing? If you're screening for any myofunctional disorders or sleep apnea, you're assessing tongue tie also. You're assessing mobility. Look at the scalloped tongue and look at the little heart shape on the upper right picture. The little heart shape there may indicate some posterior tongue tie. So we're really evaluating and assessing a lot of different things. And by the way, this is my daughter. And she has airway issues. She's thin. She's a size 0, but she's got airway issues. You can look at her scalloped tongue. Look at her. And I paid for braces. Look at those teeth. She's gorgeous. Anyway, but yeah, when we're assessed for mobility and really, really look at what's going on. So I've got a few pictures of the tongue here. So the one on the upper left, as I'm looking at it with the mirror just pushing to the side, I can't tell you how many times I've seen dentists come in and that's how they're looking at the lateral border of the tongue. We can't see that whole entire tongue. The next one on the upper right, it's a little bit better. We're grasping with the 2x2 and we can see a little bit more. But here on the lower, I don't know about you guys, but I can't stand a dry 2x2 on my tongue. Moisten that 2x2 and then I roll it up really tight and wrap it around that tongue and I can get a good grasp on that tongue and I pull it to the side and up and look at all of you can see clear back to that posterior base of the tongue, those lingual tonsils. You can see onto the ventral surface and onto the floor of the mouth. Visualize that and then palpate. Go in and palpate all of that and then do it on the opposite side.
Susan, we're
So
running a
part
little
of
bit,
the oral,
Susan, we're running a little bit long,
Yeah.
so we appreciate everybody staying, but we're already at 8:25.
Oh my gosh, I'm sorry. Okay, so glossotonsillar sulcus. This in the middle, that's a tumor. That is an HPV tumor that was found palpating that glossotonsillar sulcus right here, right back there. So palpate that glossotonsillar sulcus. Oops. Take photos and document the tongue, break it into sections. And I will send you guys my documentation. You can put into templates. Here's all the structures that should be examined. And here's some documentation that we can use in the office to be real specific about that documentation. And Diane Glasgow-Watterson had an excellent article a couple of years ago on our liabilities on this exam. And those were the things that she talked about, why we need to be so thorough with this. And just remember, if it's not right, it's wrong. React and refer. Thank you, guys. I'll send you your resources.
Anybody have any questions, comments?
Yeah,
Isn't
so
that
is
awesome?
that available surface for hygienists or just for the dentist?
Say that again.
So is that oral cancer or, oral pharyngeal head and neck exam a billable service only for the dentist, or can hygienists be included in that?
Well, we're supposed to do it too, and it's where it's billable.
Billable service or codable service? What are you asking here?
What?
We can bill for anything we want. Number
Right.
one, that's a
Pay
very
for it or
difference between a billing thing, a coding thing, and who can do it. Okay.
Right.
The Practice Act is always the first place you go to on what it can be done or not done by a particular professional. When we're talking about this is, now you use the word exam there at the end. What we're mostly talking about here, though, is screening. Dental hygienists are not only can screen, we're obligated by our education licensure and by our standards of clinical dental hygiene practice, ada.org. Go look at them because that's our minimum standard that all of us are called to. So can we do this? Yes. Is it billable? That's a different question. What we fought for at the coding meeting, and that's what Susan was talking about, is we fought for a separate code for this enhanced oral and oropharyngeal cancer screening. We did not prevail. Yet what we did win was where the comma is placed in the codes now. Oral cancer screening is part of all the evaluation codes now. What we got changed was it used to say where indicated. We had the comma was moved. So oral cancer screening, I can now definitively say, as of January of 2021, is part of every routine evaluation. Every evaluation. So it's not so are we already billing for a comprehensive, a periodic, or whatever evaluation? Yes. Is it part of that process? Yes. Is there need to be documentation for it? Yes, because if you didn't write it, you didn't do it. So does that answer it?
Yeah. Yeah.
Okay. All right.
But all of that makes more sense now that I saw her enhanced screening.
Okay. Okay. That's what we were trying to get a code for, is what she was talking about. And I wish they could have seen, I wish the coding committee could have seen this presentation too.
Amen.
Yeah.
That was fabulous, Susan. Thank you.
Thanks, Susan.
Really excellent. So Patty and Susan, I'm going to put something in the chat box actually that was just in the February 2020 Journal of Dental Education, and it's a trend where now 93% of dental schools are having dental students start clinical procedures earlier. And the reason behind it has to do with Part 1 and Part 2 of the national boards are going to be going away and replaced with an integrated national board dental exam. And so the thought is that by getting dental students involved in clinical procedures earlier, that this was going to help them in related to this new type of national board that they'll be taking. So the three procedures, or some of the procedures they're doing, and I don't know whether because they think these are easy or not, but like their early clinical exposure would be performing dental prophylaxis, conducting extraoral exams, conducting intraoral exams. So I'm going to put the citation in the chat box for anybody that's interested. So on one hand, I was like, oh, that's really great. But on the other hand, I thought, who's teaching it? How are they teaching it? How thorough is it? And are they just thinking, oh, these are the easy things that you can learn early in education to say, oh, yeah, we're going to start our clinical procedures earlier. So just kind of, you all know how I like to watch trends and trending and stuff like that. So food for thought on this one.
Yeah, thanks,
Thank you.
Noelle. Thanks, Noelle.
Now, I didn't put my email into anything there. So are you going to need that?
Who is this?
This is Deanne.
Deanne, you know what? If you got sent the invitation, we already have your email.
Okay,
so
I figured.
Sure why, actually put Nancy Brohan needs her email, Lindsay, but she doesn't. We have everybody.
Yes, as we're finishing up, Deanne, I got you. Nancy Brohan, I just need your email. If you could please.
We have it.
Send it. Okay.
We have it. If it's
also, Meg, I'm not sure who Meg is. I don't see Meg on our list. Meg, if you could send your full name and email.
Put it in the Dropbox, awesome. Please.
Chat
okay.
Box. Yes.
All right. Excellent.
Otherwise, got everybody.
Where's that at?
The chat box should be on the right of your screen somewhere.
It looks like a little. It looks like a little bubble, a talk bubble from a cartoon. Up at the top.
There we go. All right. Any other questions, comments? Thank you, Susan. It was fantastic. We're really so thrilled and honored that you took your time and your expertise and shared it with all of us. And we're going to go back again. We're going to get a code. We got to get a code. Would you? Everybody agree? Yeah. Okay. What's the recipe for insanity? Let's keep doing the same stuff over and over, thinking we're going to get a different result.
Yes.
It's time for us to do something different here. So we will make it so. Sure. Again, the next DCC, the 29th at 7 o'clock, we'll give you the full report on everything that happened at the coding meeting. And I see you're there now, Siobhan. And Siobhan already announced that you said you wanted to be a chair for next year, right?
LOL. LOL.
LOL. Hey, you said
Yeah,
it, big girl.
I love.
What is?
No, I would love to learn more about the roll, Patty, for sure.
Okay,
Thank
well,
you.
you got to remember, Patty Beeson always warns people, you got to watch what you say to me because I'll I'll remember it and we got to figure out how to use it. Also,
Yeah.
He'll bring it back and you'll say, oh my God.
Again, our next study
Why?
club is on the 15th, Wednesday, the 15th of April, tax day, although who knows what's going on with that. And again, our wonderful Noelle Paschke is along with her husband, Rich, will be talking about ultrasonics, all things ultrasonics. You know where to find me. Text me, email, Facebook me, instant message. And our Beyond Oral Health message at the end is Beyond Oral Health helps you shift your mindset to reach your goals and change the future of healthcare. We're making the world different and better because we're part of it and everything that we do and every way that we do it every day. Thank you for joining us and thank you so much for your time. And I wish you all a very good night and a very safe future.
Stay healthy,
Yes, thank
everybody.
Stay healthy, everybody.
Thank you.
For
Good night,
sure.
all.
Good night. Thanks. Okay, how do I get out of here?
So my information isn't going through to you. Are you still there?
I'm still here.
Meg,
I got you, Meg. Is this Meg?
my email, did you get it?
I gotcha. Yep.
Okay.
Thanks.
Got it? Perfect. All right.
All
Good
right.
night.
Night.